I'm going to start with introductions, and I'm seeing some new faces in the room, for which I'm grateful. I'm glad that there's interest out there, and I'm glad that people are hearing about our presentations. This presentation is another of our series of Grand Round, Correctional Medicine Grand Round presentations. They're designed for medical providers in corrections, but they're certainly, we've had lots of participation um, by nursing, mental health staff, and others who have an interest in our topics. Everyone is welcome. These proceedings are all free. We have stopped doing the CME because that's what was costing us all the money, and we decided that people weren't all that interested in the CME. You can get, I know that through the AAFP, you can claim, you can claim non-essential. I forgot now the terminology, but you can still claim credits even if it's not an accredited presentation. This is a work in progress, and we'll see where things are going next year with this. But for this year, we're going monthly, and we have some good presentations planned for the future. These belong to the ACCP. We don't make any money off of them. Joel doesn't get paid. We depend on volunteers to help us and to present to us out of the interest of educating others and out of the goodness of their own hearts. I'm not going to spend a lot of time introducing Joel. Most of you know who he is. Joel has extensive experience. I've known him for, I'm sure I've known you, Joel, for 20 years or more in the correctional field. I know him to be a fantastic speaker, and I was thrilled when, after we hadn't been in touch with one another for 3 or 4 years, he agreed to do this nonetheless out of the goodness of his heart. And I'm sure that he spent a lot of time preparing, and your gratitude toward Joel and all our speakers is much appreciated. I'm going to just get started. Go ahead, Joel, and I'll be putting myself on mute. I'm going to ask you, we haven't discussed this, Joel, if you want to be interrupted, that's fine, but our usual way of running this is to have people put questions in the chat room. I will monitor the chat room. You don't have to mess with that. If it's an important question, I'll raise my hand and interrupt, and otherwise I'll just let you roll and be sure and save 10 minutes at least at the end, so that we can have a conversation, discussion. This topic, I think, will drive a lot of questions. Even at this late date, people still have lots of questions. We've been dealing with this for, I don't know, going on 10 years. I don't know when your first program in Massachusetts was, but you can say more about that yourself.
Sure. Great. Thank you. And yeah, if anyone has questions, I can see only a few folks, and I think I'll see the chat if it pops up. But Mike, if there's a question, just come off mute and ask. I want it to be as interactive as possible. I'll just give a quick background of who I am. Joel Andrade. I'm a clinical forensic social worker by training, the PhD's in social work. And I've been in correctional healthcare now 26, 27-ish years. I started doing an internship thinking I was going to work with juveniles, and I thought I'll do an internship in corrections, and I loved it, and I've never left. And as Mike said, my background, half in forensic practice and then half just straight correctional healthcare. And for about 5 years, I was the director of mental health in Massachusetts and became intimately involved with providing care for this population, and really just gained expertise during that time. So a lot of this will be based on my experience. I'm going to talk about some legal issues, but focus really on clinical issues for healthcare providers, more physical health, but I'll get into the evaluation on the mental health side as well. And again, any questions, feel free. And if I know it's going to be answered later in the presentation, I'll just say that. But If not, then we'll have a discussion midway through. So the main objectives, which were in the invitation email, really just to gain knowledge, and I'm sure most folks on here have it, of the diagnosis of gender dysphoria. So I'll just go through that quickly. Then talk about the WPATH, the World's Professional Association for Transgender Health, their 8th version of standards of care. And then really just talk in correction specifically, the referral process, and then an overview of litigation. I don't want to focus on litigation, but this is a litigated issue. And I just want folks to be familiar with clinical practice and some legal ramifications. So this is the outline. Again, DSM, diagnosis, WPATH standards. I'm going to talk about some of the unique aspects in corrections, which we'll have a brief discussion on, then the referral and approval process, and again, that legal overview and discussion. I like always to give the take-home message at the beginning, because if folks are like me, my attention as I get older is less. So I like to do the take-home message at the beginning. And basically the main themes of this is really just to put the patient first, make decisions on a case-by-case basis. There's no blanket policy or blanket type of assessment that is, the silver bullet that gives us the answers. We really have to just take each case as it comes to us, be as thorough as we can, and make as best clinical decisions as we can in the moment. And as medical and mental health professionals, just refer. If there's any question about someone you're working with that may have gender dysphoria or transgender health issues that need attention, as a medical provider, refer to mental health and get that person the help they need while they're in your care. We'll talk about communication. And I know in corrections, when I started back in the late 90s, we were always told, stay in your lane. And now I preach the opposite, that we really need to really be multidisciplinary and not be in silos, communicate. Obviously, mental health providers are not physical health providers and vice versa, but we need to shift into each other's lanes here and there. Really mostly communication, but be transparent with each other. And then the bottom line, this can be occasionally we'll have a really challenging case, but just treat everyone with respect, when it comes, all our patients, which I know this group really does. This is a pretty basic slide that I like to start with. Again, for this group, it's probably really 101, but gender and sexuality are very different, right? Folks get, and in corrections, sometimes things get misinterpreted or stereotypes, but really to look at gender, and I liked, this has been said a lot, to think of gender as who the person goes to bed as, right? I'm a male, I'm a female. In sexuality, who the person prefers to go to bed with, right? Who they're sexually interested in, their sexual orientation or attraction, which can be very different, right? Someone's gender identity and their sexual identity, very different. So to, really just start with that foundation. Let me see. I'll quickly go through the DSM diagnosis. As folks probably know, DSM-5, which came out in 2013, had some pretty significant changes for this diagnosis. The text revision that just came out 2 years ago in 2022 didn't have significant changes since then. So we'll go through, but we're going to go through the current diagnosis in the DSM text revision. And like all diagnoses, there's just a list of criteria. And I think there's 6 here that we're going to go through. If someone meets any 2 of these, they meet criteria for gender dysphoria. Why is this important in corrections? We'll talk about it. And why it's still in the DSM, for access to care issues. But we'll talk specifically about why it is even a diagnosis anymore. So any two of these following six. One, a marked incongruence between one's experienced or expressed gender and their primary sex characteristics. Two, a strong desire to be rid of the individual's primary or secondary sex characteristics. Three, a strong desire for the primary or secondary sex characteristics of the other gender. Four, a strong desire to be of the other gender. Five, a strong desire to be treated as. And you can see these are self-report, right? This is someone's subjective experience of their gender. There's no, in corrections, folks want to say, is there a test? Is there some kind of evaluation we can do to guarantee that we're correct? No. And gender identity, as we learn more and more, is fluid, right? So some folks have a very solid gender identity. They identify as male or female, and that's consistent. Others, it's more fluid. So again, the diagnosis is really subjective and based on the person's experience and how they identify. And then the last, number six, a strong conviction that one has the typical feelings or reactions of the other gender. So again, really subjective. And as a mental health professional, just spending time with the individual to process and determine whether they meet this criteria. And typically, if the person does report that this is their experience, you err on the side of caution and they have the diagnosis. Criterion B, like in all DSM diagnoses, the condition is associated with clinically significant distress or impairment in these domains, social, occupational, or other areas of functioning. And then DSM-5 in the text revision ask us to specify whether there's a disorder or difference of sex development and whether the individual is post-transition. And we'll talk about why those things are in there. So the main changes, DSM-4, and the tech, I think DSM-4 was 1994 and DSM-5 came out in 2013. The big change was the diagnosis was no longer labeled as a disorder. DSM-4, it was called gender identity disorder. DSM-5 took that out, and really just so it wasn't as condescending, right, that it's a disorder, it was gender dysphoria to kind of take away the stigma. It's its own specific chapter in DSM-5. In DSM-4, it was in the paraphilias and sexual function disorders. So as we talked about at the beginning, sexuality and gender are different. And DSM-5 recognized that and took it out and put it and gave it its own chapter. Adds post-transition specifier, and really that's to ensure access to care. Even if someone has gone through full transition, they still need medical services, right? So still need to bill insurance in the community to have that access to care. DSM-5 deleted. There was a specifier who the individual was attracted to sexually. Obviously, that's not important, doesn't inform someone's gender, so that's been taken out. The not otherwise specified was taken out of all DSM diagnoses. So that is the case here as well. And added in replacement of NOS, not otherwise specified, other specified disorder or unspecified dysphoria. Again, that's a real quick overview, but I want to just give it as a background so folks know when mental health is evaluating, this is the criteria we're going by. And then the rationale for the changes, like I said, to remove stigma, took out the label disorder, replaced it with dysphoria. And there was a lot of push on the DSM, the committee, which was sexual disorders and then gender dysphoria, to completely take the diagnosis out, right? Like why in the 70s, homosexuality was taken out of the DSM. It was in before that, believe it or not. And it was viewed, it's not a disorder. Why is it it's not a psychiatric condition, it's someone's sexuality. So why not the same for gender dysphoria? And the reason, which the work group gave, is really that access to care issue. So to get insurance coverage in the community, an individual needs a diagnosis, right? Something that's billable. So the work group was concerned that they were leaning towards taking it out, I think, when you read and put things together. But they were concerned that removing it completely, individuals wouldn't have the access to care that they need by, billing. So that's a very quick overview of the diagnoses, but I think it's important as a background. And now I'm going to just talk a couple slides on the WPATH. So the World Professional Association for Transgender Health is a consortium of professionals worldwide that back in the 70s were professionals, surgeons, social workers, psychologists, psychiatrists, who were working with this population in the community, and there were no standards. There was no set way to engage this population in treatment. So that group formed and wrote a very brief standards of care. I think it was 12 pages at the initial iteration back in 1979. The most recent came out 2 years ago, 2022. The 8th version is now, I think, 260 pages. So a lot more dense, and there's a lot of information in there. It is publicly available. You can Google it and download the standards of care in a PDF. And in corrections and in the community, but specifically in corrections, the courts look at the WPATH standards of care as the gold standard. So the DSM-5 diagnosis is one thing, but access to care and then the requirements set forth by WPATH really gets viewed by the courts as the gold standard, and that in the community. I'm not going to get too into the standards of care. Like I said, they're accessible. You can download them and read them. There were some pretty significant changes in the standards, and I just highlighted a few. And really the changes were to decrease barriers to care. There were requirements in the 7th version that required a mental health professional or 2 mental health professionals to write a letter for an individual to receive surgery. I think it was 1 to receive hormones, and that a lot of those things have been reduced. And in the community, if a patient identifies as needing surgery or hormones and their provider is willing to do that, no letter is required. But for surgery, most physical health surgeons do want a letter from a mental health professional just saying there are no mental health reasons that would interfere with this. There's no person's not psychotic or delusional, and in fact surgery would decrease their dysphoria or experience of depression and anxiety. Really just a clearance for the surgeon. The 8th version also removed some of the minimum age requirements, really just decrease a lot of the requirements to increase access. In corrections, there are some unique aspects, right? Like in the community, if someone self-identifies, there's really not much question of any secondary gain or other reasons the person would identify, right? It's either, you'd want to rule out other mental health conditions like a psychotic or delusional disorder. But in general, if that's how the person identifies, that's how they identify, right? In corrections, there are, as always, right, with everything, some additional considerations, right? So first, a lot of legal issues, which is unfortunate. As a mental health professional who's worked with this population, the majority, are self-identify and really just need treatment, whether that is just acknowledging the person's identity and calling them by the pronouns they prefer or their name. And in most cases, they've legally changed their name to either a female or typically female or masculine name. And just to refer to the person that way, to allow them access to gender affirming clothing, things like that in corrections are hard to get. And it's unfortunate that a lot of our patients we work with that have transgender health issues have to go that legal route, right? I think most departments are much better now at allowing everyone access to their preferred undergarments, things like and deodorant, hygiene items, and don't have those barriers in place, which I think is really commendable, and most departments should allow that. But obviously, there's always going to be legal issues, which leads to difficult assessment, right? It's hard when folks are all right. We were not recorded, now we're being recorded again. But it makes the assessment challenging. Oftentimes, the patient perceives an adversarial relationship. You're my physician, I need you to write an order for X, Y, or Z, and you're not willing to do it. You're my mental health professional, and I need you to refer me for hormones or surgery, and you're not doing it. So it does create an adversarial relationship. Personally, and I've seen a lot of really good mental health clinicians be able to address this pretty quickly with patients, but oftentimes patients come in and see us as a barrier or roadblock. So really just having that discussion of, I want to get you the services you need, but I need to hear about what you need. So let's have that conversation. And it might take a few conversations. I can't immediately make these changes. So really addressing that head on is very helpful. A much smaller group, when we talk about the secondary gain or unrealistic expectations, it really is very small percentage, like 5% of folks who self-identify do it for reasons that are disingenuous. But that in corrections, that does happen, right? Sometimes it's just for safety issues that the individual knows if they self-identify, they'll be placed in a certain housing area where they feel safer, or other issues. It might be, and you have to differentiate in those cases. But really, in my clinical experience and talking with others who have worked with this population, the majority of folks who identify in corrections fall into these two groups. Folks that have the lifelong history, that will tell you, I knew since I was 6 years old, and they'll talk about how they express their gender throughout their life, right? And then we do see quite a lot of folks who have a kind of late life emergence. Caitlyn Jenner is a good example of that, someone who may have known lifelong, but due to societal pressures, whether it's family or just socially, tried to bury it, tried to deal with it and not identify as male or female. And then later in life, it came out. And we do see that quite a bit in corrections, right? And then again, so that those two are like 95% of the folks that we work with who self-identify. There's two very small groups, and this is again based on clinical experience, not research. But folks that just have significant identity issues that are, whether it's gender is part of it, but there are other issues, oftentimes with comorbid personality issues, substance use issues, sexual issues, that may identify as transgender, but there's a lot more going on that mental health can help the person address. And then again, that very small group, less than 5%, that there is some kind of secondary gain, whether it's safety issues, sexual issues, or something else. All right. So now I'm going to get into just the evaluation process and then some recommendations for all departments, whether they're large state systems or small county jails, to have some of these evaluation processes and referral processes in place. Right? Not all staff, physical health and mental health, um, have specialized training with this population. So we want to identify staff that do, um, and so that populate, so that those group of clinicians can evaluate and treat this group. And really, every system needs to have these three processes: a way to identify folks, to diagnose the individual so they can get treatment, and then third, a way to provide that treatment, right? And these are general, again, I've seen large state systems like Florida that have these, and then some small county jails that have less than 100 folks that also need these kind of processes in place. So referral is extremely important. If someone self-identifies or not, if the individual you're working with doesn't identify, but you have concerns that they have some gender identity issues, and if they worked with mental health, it might be helpful for them, a referral definitely makes sense. And really all of us, physical health, mental health, custody, are responsible to identify and refer. If the person self-identifies or we have concerns. And that also acknowledges and recognizes that not all of us are expert in this area, right? We just need to know there's a process in place to refer the individual so they can get the care they need. And then these are just some potential examples of referrals, right? The individual self-identifies and says, I know I was natal male at birth. I am a woman and I'm being treated like a man here. What do I do? And then you would refer the person so they can receive treatment. The person reports previous gender identity issues. And then the last one is the example of someone who doesn't identify, but let's say you're a mental health professional and you review disciplinary reports as part of the mental health input into the discipline process, and you see this one person keeps getting disciplinary reports for destruction of property related to changing their clothing to be more feminine or more masculine. That might tip you off that there's something going on, and a referral would make sense, right? And then in corrections, the stepwise process, right? So to receive treatment, whether it's in some departments, unfortunately, a diagnosis is needed just to access those items like clothing and hygiene items. Fortunately, most departments are changing, so that's not required. And a lot of folks, then they don't need anything. They don't need to see mental health. They don't need to see medical for any interventions. They're satisfied dressing as male or female and having the hygiene items that they prefer, right? And they don't want hormones or surgery. For those that do, then the diagnosis of gender dysphoria, the mental health professional gives that diagnosis. In larger systems, there are treatment committees and supervision groups, which we'll talk about a little bit, but a process for that, right? So mental health would do the initial diagnosis, and then we'll talk about the process for referrals for physical health interventions. But for hormones or surgery, once the person, the mental health professional or team determines that those interventions would alleviate dysphoria, then that referral is made to physical health. And then there's a lot of communication, right? So I've worked in systems that the medical staff are like, I've never done this. I'm not prescribing hormones. So we would find a way to get the person in front of an endocrinologist or someone with experience. And honestly, over the last 10 years, a lot of medical departments in corrections are receiving that training, right? So folks feel more comfortable, physical health docs prescribing hormones or referring for surgery. But again, a lot of communication. Like I talked about, the whole stay in your own lane is getting old, right? We need to communicate and work as teams and not in silos. Larger systems, a lot of state departments of correction have established treatment committees, typically comprised of the mental health director for the state, the psychiatric director, and the medical director. So in Massachusetts, that's the model we had. So I was the behavioral health director, our psychiatric director was on, and our medical director, and at that time was Dr. Tom Grabowski, if he's on here. I know a lot of folks know him. And we would meet once a month and go over all of our patients and have really, some were very easy, quick discussions, and some were just very detailed, and really clinically rich discussions about how to provide the best care for each individual. And then that committee would typically take either requests from patients for interventions or referrals from mental health staff working with the group or medical staff, review the recommendations and approve them. And again, that's usually larger systems and departments. Smaller facilities, jails, may just have one or two folks that are trained, and there's a process for that. But again, every department should have a policy that outlines that process for folks. And as a mental health professional and working with mental health professionals, I would often hear folks say, I'm mental health, I can't order hormones or surgery. And we would say, no, you're not. As a mental health professional, you're just determining, does this person have dysphoria that intervention would help address, right? Like I'm a clinical social worker. I'm not a psychiatrist, so I won't prescribe antidepressants. But if I'm working with a patient that's depressed and I think a medication evaluation would be helpful, I'll refer to psychiatry. Same here. As a mental health professional, if we think the person's dysphoria would benefit from initiating hormones or having surgery, and there's lots of different variations of surgery, right? We have a process in place to make those referrals. And then vice versa. Oftentimes we would make a referral for hormones. A very experienced endocrinologist would see the individual and have questions. Is this person competent? I have some concerns about whether they're delusional, and then we'd communicate back and forth, really just to ensure the person receives the best care they can. And again, the majority, very clear cut, communication, evaluation, and then treatment. And then every system does this differently. And with the progress of remote services like telehealth, a lot of patients have easier access to endocrinologists and folks who can prescribe hormones. And then also to have a process for surgery, right? To have, in some states, have really good university-based hospitals that there's a good relationship, and then they have a lot of experience working with this population and providing surgery. In those cases, again, there's a lot of discussion because some surgeons are concerned about performing this surgery on someone who's incarcerated. So I've had to have a lot of those discussions, but in the end, most feel very comfortable once they feel reassured that the person has received all the proper evaluations and the treatments necessary.
Joel,
Yes.
we have some questions in the chat about housing and how custody plays into all of this. And I'm guessing that you're going to get to that, but they're not clearly custody doesn't belong on a treatment team, except in as much as housing becomes an important factor. And if you were going to get to that, then just proceed. But questions are coming up around that issue.
Yeah, no, that's a great question. Yeah, we'll talk about it right now. I think I have some, but yeah, it's very challenging. Um, most departments still house folks based on the gender assigned at birth, right? If someone's natal male, even though they identify as female, they may be on hormones and present as female, the system houses them in a male facility. More departments are allowing folks to self-identify their preferred housing. And in many cases, the person gets transferred. There have been some bad outcomes, right? I think folks, if you've read, New Jersey had some issues. They were allowing folks to be housed at the female facility who hadn't had surgery yet, and they had a couple issues. And there are going to be, I tell security folks, directors, secretaries, all the way down to wardens, superintendents, captains, there's always issues, right? Like we can't say no to everybody just because there are a couple issues. There's always going to be issues. Right? We allow folks who get in fights to hopefully go to restrictive housing for a very short time or not at all, and they're back out. But that's a bad outcome, right? Fights and assaults. And this is going to happen with this population. But if you have a good process that, mental health's evaluating the person to say, yep, there's no secondary gain. Security does a genuine review, not just a rubber stamp, no, you're staying at the male facility. In general, you can, in departments that do transfer folks to their preferred or their gender identified housing, if they allow the majority that self-identify and deny some because there is evidence that there are significant security issues or that there's concern about identifying for some kind of secondary gain, you're much better off, right? Like you're doing the right thing. And for the, you've transferred 50 people and these 3 you have concerns about, so you've said no. But again, some departments really have a blanket policy, or it's not in policy. They say case by case, but they never transfer. And that's an issue.
Do you know of any legal cases? Whoever is speaking, please raise your hand or whatever, and or mute. Is So do you know of any cases that the housing has come up? I mean, I know that there are grievances all the time, and and what happens after a grievance. But so for example, a trans male with a beard and a mustache and on hormones in a female facility might be grieving, I mean, and maybe correctly so. Right? Can you just comment on that if you know of any cases? Or I know you're not a lawyer and you're not
Oh,
speaking
no.
as a lawyer, just
Right.
up front.
Yeah, I mean, I think and we'll talk about a couple cases related to surgery, but they also talked about housing in them. And typically courts,
email and I've never heard.
Typically courts do defer to security issues, and we'll talk about one case in particular, Massachusetts case. But some department, I know California has really opened that process up. Massachusetts has, I think Pennsylvania. So there are systems that are allowing folks to transfer, again, through that evaluation process, security and clinical. Legal cases, I'm not sure. I know there are a lot, and folks will litigate this issue a lot. But the ones I'm going to talk about are more related to surgery. And then the question of what's medically necessary, right? So like I was involved in
Thanks,
cases.
Joe.
Oh, sure. In cases early on that I'd hear the argument, well, they're not going to die, so it's not medically necessary. Is that the definition for this? No. Unfortunately, the courts, and we'll get into a couple cases, have very different findings and orders, right? So some have ordered surgery and say it's necessary to treat the dysphoria. Others have said absolutely not. So in general, I recommend that the definition of what's medically necessary is something along these lines, that like without the intervention, the person will experience significant dysphoria, and implementing a certain intervention will alleviate that dysphoria, right? So is an antidepressant medically necessary? Probably, right? If the person has significant depression or anxiety, is that medication necessary? Yeah, it will help alleviate those issues, right? And then in general, for your system, just to have a policy and a real process that minimizes any roadblocks. And again, with the population will feel like it is a roadblock. Why do I have to see mental health 3 times before I get the diagnosis? Why don't you believe me? You know, that does feel like a roadblock. But if you have a really streamlined process that minimizes those issues and no ridiculous hurdles, right? Like, and you know, in your own systems, if that policy is written a certain way, it is to create roadblocks and hurdles. And as clinical professionals, we really need to advocate to minimize that, right? Obviously, we need good referral processes and evaluation process, but minimizing the roadblocks and hurdles. And this we already talked about, so let's skip it because we're getting a little short. And I'm gonna, like Mike said, I am not a lawyer, but I've hung out with a lot, unfortunately. So I've learned a few things related to this. So I'm gonna go over some legal cases to make recommendations for your system, right? So we all know that first case, Gamble Estelle, it's deliberate indifference. If someone has a serious medical condition that we don't treat, right? If we don't have a process to do that and we know about it and we decide not to. A year later, in Bowering Godwin, psychiatric conditions had the same protection under the 8th Amendment, that if an individual has a serious medical or mental illness, that they require treatment. And if you know about it and do not help that individual, you're deliberately indifferent. And then a lot of courts have found, federal courts, that gender dysphoria qualifies as a serious psychiatric condition, right? So you'll hear arguments, folks saying it's not a serious condition. That's been litigated and very consistent throughout the country. If someone has gender dysphoria, they need treatment. What that treatment is, we'll get into, right? There have been very different legal findings. Constitutional violations that have consistently been found, that policies violate the Constitution. If you don't have a process to evaluate for gender dysphoria, if you decide not to treat it, there, believe it or not, some departments years back that just said we don't do that here. Using just supportive therapy is not okay. That's a constitutional violation. And then there were policies that were called freeze frame policies that said if the person came in on hormones, we will continue them, but we don't start them inside. And obviously that made no sense to the courts, right? Like if someone comes in and then they're not depressed or they don't have diabetes and they develop those conditions later in their incarceration, of course we'd treat that, right? So if someone comes in not identifying and years later they identify and hormones would be helpful, you can't just say no because you didn't come in on them, right? And that's consistent in the courts. Policies that exclude certain interventions. So a lot of policies evolve to say we will do hormones, but we don't do surgery. Again, the courts say you can't do that. They're not saying you have to do surgery on everyone, it's case by case, but you cannot typically, and we'll talk about one case that actually says you don't have to. And then this one I just include because it jumped out at me, but in Wisconsin, the legislature tried to put into state law that surgery or hormonal treatment for incarcerated folks is illegal, and that became law and then was litigated and found to be unconstitutional, right? So even attempts by legislatures to say no have not worked. And then these are a few things that I think increase your liability as a practitioner in your department. Allowing non-clinical personnel to make treatment decisions. Like I've seen some systems that the ultimate decision maker was, like a deputy secretary, deputy director, an attorney, someone who didn't have a clinical background. Yes, there are some committees that those folks participate in, and maybe just for informational purposes, that's one thing, but cannot be the ultimate decision maker, obviously. Also not developing internal expertise, right? Whether it's mental health folks or medical providers that have experience with this population, I think increases liability. Typically, especially in larger systems, those folks self-identify, right? Like I've worked with this population in the community, I'll take that person on my caseload. And then they bring their expertise inside. And then if you're in a system that doesn't have anyone with that expertise, not bringing someone in with some expertise to train your staff or provide consultation on more complicated cases, that also increases liability. And then I'll quickly go over these legal cases and leave a few minutes for question and discussion. Typically, folks do ask a lot of questions about surgery, so I went over the more recent cases. The early ones that the court ordered surgery, and I'll say the name, this is all public. The first one was Koselik in Massachusetts in 2012. That one initially the court ordered, and then the Department of Correction appealed, and the 3-judge panel reversed that order. And when you read it, their rationale for saying no to surgery, the court, was based on the unique aspects of Massachusetts, saying this person, Michelle Koselik, was convicted of murdering a woman, her wife, and there's only one female facility in Massachusetts. It's very small. The majority of women incarcerated there have trauma histories, and it would be a security issue for that population. And the court said, yeah, I'm looking in front of me and I see you have a treatment plan, that you're on hormones, you're seeing mental health, you're very active, doing well without surgery. And then this other treatment plan that's being presented that you need surgery, I'm going to side with the department, and basically because of those security issues. And then similar time frame in 2015, I think the name was Norsworthy in California. Court ordered surgery, and the individual was released on parole or probation. So that happened pretty quick. And then the first, I think, court ordered surgery was a case in Idaho, Edmo, in 2018. The court ordered surgery. It got appealed, and the department lost, and it went to the Supreme Court, but the Supreme Court didn't hear it. And folks were hoping that the Supreme Court would hear it to give some kind of language to say when things are necessary and when not. And then there's a conflicting order in the Fifth Circuit. So Idaho's the Ninth Circuit. In Texas, the case was Gibson in 2019. And that court said surgery is never necessary in corrections, which is very different than Edmo. And again, the Supreme Court hasn't heard it. So there's very different legal precedent between the First Circuit and the Ninth. So first is Massachusetts, kind of New England area. Ninth is California and a lot of the West Coast. And then the Fifth Circuit is Texas And in the Fifth Circuit, no, that's the Gibson case said, no, it's not necessary. And those are just some of the quotes. And then just conclusions, and then we'll have a quick discussion that your department or facility really needs to have a solid policy of how this population is evaluated and then receives treatment. And so know your referral process, train new staff on the referral process, refer the individual whenever there are concerns, right? It could be late in someone's incarceration or at intake, but not to, as a medical professional or mental health or even security, this person's been in for 30 years, it's never been an issue, why am I going to refer them? That does happen a lot. We've seen lots of cases that the person says, I tried to deal with it on my own, I didn't want to identify this way, but here it is. And they identify later in life and later in their incarceration. Whenever you're unsure, seek consultation, right, with all issues. Ensure that there's that comprehensive policy that minimizes any roadblocks, has rapid ability for assessment, doesn't exclude any interventions. There's no one size fits all. And then just legal conclusions that there are a lot of cases and very little precedent, other than, yes, if someone has gender dysphoria, they're entitled to treatment. There's some differences in surgery findings, and really just to individualize your assessment and your treatment plans. And with that, I'll stop sharing and have some discussions.
So one of the questions that's coming up a lot in the chat is access to care and finding somebody in your community, and particularly in smaller communities, rural jails, etc., and how you can actually access care, and if there's precedent for primary care physicians for doing the hormonal treatment in particular. One person said their policy, I think you've solidified that question, said that their policy in a mid-sized jail was to continue hormone treatment if they were on it, but not start it in the jail. And I think that that's pretty clear cut, and you've already spoken to that, so we don't need to discuss that. But one of the reasons for that might be that the person was quoting from a small jail in Idaho, and how do you access care? And so I had questions. When those questions came up, I thought, well, telemedicine. One person said, what about how much training is there for primary care physicians to prescribe? And I'll shut up now.
No, it's a great question. And yeah, the first way is through tele. And if you can get an endocrinologist or internist that is their they work with this population regularly, that's great. I'm forgetting the name of the service. There's also just a consultation service that some of our physicians felt much more comfortable if they consulted with an endocrinologist, went through, and actually I can share with you, Mike, there's a journal article by the Endocrinological Society that talks about this and how a referral and consultation, and then the on-site physician actually writes the order, so there's a lot of discussion, training for that process to happen. Again, folks need to be open-minded and comfortable with that. But I'd advocate that folks should. And if the ambivalence is just lack of experience, there's ways to get that experience and ways to just receive consultation. And yeah, if you don't feel comfortable with hormones initially, that process does help. I know someone on here might know the name, what that service was. I think Florida used it because in Florida, right, it's a huge state, and some facilities are in really rural areas with not a lot of access to endocrinologists or outside care, and others maybe in Miami have a lot of access, you know. So patients, even within one system, experience a lot of differences in care. But that kind of consultation is the way to go.
Dr.
Rudy,
Andrade,
Rudy
Dr. Andrade,
Nunez is, go ahead, somebody speaking up, go ahead.
Dr. Martinez, Dr. Andrade, are you thinking of Rubicon?
Yes, I think that was it. Yep.
Yeah, that is
Glenn,
what I'm with Florida. That is what we use for specialty.
yeah, and Rudy Nunez, who's one of our past presidents, was suggesting that use CSF. Rudy, speak for yourself. I think I don't know if that's a way to get telehealth referrals, or if they have online resources for primary care physicians.
So they have protocols, especially to start if you want to start in hormone therapy. So, but there was a colleague that had mentioned to me that their hormone therapy is very well established. So it's important that sometimes with these jails that are remote, and sometimes we don't have an endocrinologist that can, be of service, that we as providers start, getting to know some of these protocols and maybe initiate them. So from a legal perspective, I think it's important that we, start using hormone protocols, especially when they're in a remote facility.
Absolutely.
Yeah, and we've established that telehealth is a reasonable way to go if you can find some telehealth. We have two juvenile folks in the room, and I wasn't going to bring it up, but one of them has brought up the request by wanting to be trans male to have a bilateral mastectomy while incarcerated in the juvenile system. And I think that this is the area that I wasn't going to bring it up, but I actually wanted to, but I thought, well, this is the most politically charged area in gender dysphoria, is the treatment of juveniles. And I personally haven't decided what I think about that, because I think there's so much flux in the adolescent time around identity. But so is there, can you give us any guidance on that, on the issue of juveniles, incarcerated juveniles who are making these very difficult requests, particularly if they're in distress? I mean, that was the criteria, was distress. Right? Am I on this?
Yep. No, absolutely. And it is, and has become in the last like 7-8 years, much more politically charged, right? Like some state legislatures have passed laws that make it illegal for providers to provide that type of care, right? I think Texas was one. And then other areas that not at all, so folks can, if you live in the Northeast, it's a very different experience than in Texas if you're a juvenile with gender dysphoria or gender identity issues. There is a lot of research out of Europe that does talk about this. The Netherlands has really good systems, and I have some of those articles that I can share with you, Mike, to share with the group, that they have just really, really good protocols, and they do approve like puberty suppressing treatments, whether it's hormones, in some very, again, it's smaller numbers because it is, like you said, a very complicated, thorough evaluation process, but they have found some good outcomes, even having surgery, during puberty and puberty stunting hormones. Again, it's controversial here, especially in certain areas. And that's the community. Then you add corrections on top of it, it becomes even more. But yeah, I think, oh yeah, someone just wrote Endocrine Society guidelines, and those are the ones. I think they came out 2018, and they're really good. But yeah, it's a huge issue, and I think just departments that allow folks to identify the way they want to, access items like clothing, hygiene items, call folks by the pronoun that they want and the name that they want, as long as it's, we have some that may have these names that you're like, I can't call you that, that's inappropriate. But if it's an appropriate name, yes, like treat people with respect and we will get away from a lot of the adversarial, litigious. But again, you are going to have a group that it's a tough call. You have a 16-year-old natal female that wants puberty stunting hormones. That's really challenging.
Yeah, I don't, Michelle Stapleshorn is also in the room. I know that the two, I think it's really appropriate what you're just saying, because the two people in the room, one is from Oregon and the other is from Georgia. And I don't know if Michelle has been the director of juvenile in Georgia for so many years, and I don't know if this has come up in Georgia.
Yeah,
Hi, Michelle. It's good to see you.
Hi, Mike. Hi, everybody. I've been listening because it's been primarily, adults, but for the kids, we've never allowed the surgery initially. We did allow, if they had initiated hormones in the community, that we would allow them with parental consent to continue, but we now have legislation that does not allow us to do that in Georgia. So unless they're over 18, which, sort of excludes most of my population. So we're prohibited in providing the hormone therapy. However, we are able to accommodate children that are identified as transgender if they want to dress, in the gender that they feel they belong to. We will do specialized treatment team meetings to determine what type of facility they need to go to, female versus male, and also honor requests for name changes, pronouns, and also if they, as far as searches, we allow them to identify the gender of the person doing the searches.
Great.
So Michelle, just a follow-up question for you. In Georgia, it sounded like you have custody on the treatment team, or is that a separate, different
Oh, I'm
team that's
sorry.
making
No.
decisions about housing? Because that came up earlier, and I think it's an important issue, because that's the issue everybody brings up. Is where are we going to put this person? How do we house this person safely, and etc. So I'm gonna be quiet, because
Yeah,
I heard you say custody was involved in the treatment team.
we have the policy covers custody, medical, behavioral health, everyone. So everyone is involved in the treatment decision, our classification system, etc., in the placement decision as to where the child is going to go with regards to the facility. But everyone has to follow that same policy with regards to the child requesting what gender does the searches, following the pronouns and the names. All of that is within the agency policy. So everyone is required to follow those policies and those requirements. We're just not able to continue the hormone therapy medically when they come in.
Well, we're going over, but I think there's precedent for that if you have patience for it, Joel.
Yeah.
Marcia, do you have anything to add to this? You're the catalyst to bringing this more difficult topic up. I'll just leave it to you to speak for yourself if you want.
Well, yeah. So we have a youth who wants to be male and has been on hormones. And at about age 16, he started asking for surgery. We did send him to the surgeon to see if it's medically necessary. The surgeon said, if there's gender dysphoria, he didn't like insist on it. He just said it could happen because the youth wants it. But in a correction setting at that age, we just didn't want to, we monitored the youth to make sure there was no suicidal ideation or anything like that. But now that the youth is 18, the youth is telling us, I'm 18 now. I think I can have the surgery now. And this would be the first surgery if we went through with this in our setting. And so I'm a little leery about that. And I thought I wanted to come to this meeting to just get some ideas. And I was glad to hear what you said about the policy, because I was about to write a policy that says we will provide hormones, but not surgery. So I was glad to hear you clarify that.
Yeah.
And so, He's asking about it, but his focus is on some other things right now. He has some other medical issues going on,
Yeah.
and so I'm trying to sort it through. Yeah.
Right. And then the surgery raises other questions about, fertility. So like there's a lot, someone's adult and they're natal female and transitioning to male. There's that discussion. Do you want to, extract eggs and freeze them? Because that's that's a possibility. And same someone who's natal male to female, but when it happens early, pre-puberty, that's not an option. That's another discussion. And I know, so is your person asking for double mastectomy, top surgery?
Yeah,
Yeah.
top surgery. Yeah.
Yeah, and I haven't heard, I know in adult corrections, yes, there's been several. I know in New England a bunch, California a lot. I don't know in juvenile of any. I haven't heard.
Yeah.
But
Well,
yeah.
thank you. I haven't heard either.
Yep.
Well, thank you for that, that help to kind of help.
Okay.
Yeah, thank you.
Sure. Thank you.
So, the only other person who's raising some issues is somebody named Dawn Davis, who I haven't noticed or met before, who has said that number one, that primary care providers in the community are definitely at this point, many of them are getting specialized training and are prescribing. And that's an important thing for us, is to know what the community standard is. But also some questions about mental health, not being willing to touch, quotes, not being willing to touch a transgender case. And I think that's a time to get a new mental health provider in. That's my personal opinion. But
I wish that when I was a medical director of the county jail, I had that power. But I did not have that power.
Yeah, I mean, again, it's hard in smaller areas and especially rural areas that folks don't have the experience. And will say, I'm again, like, I don't know.
I was in a metropolitan area.
Oof, that's even worse.
Yeah.
so, and then somebody
folks can get training to feel comfortable. There's there's like the group that's like, I just don't feel comfortable. I haven't done this. I'm open. But I don't want to do anything wrong. That's great. Let's get a consultant, have some discussions, get some training, and get you to the point you feel comfortable. But then there's others that say, I have a religious belief, or, and you're like, yeah, it's a diagnosis that needs treatment. Sorry. Yeah.
And then there was the last question about payment for services. Are they covered by the medical vendor? And I think the medical vendor better pay for whatever is prescribed in the prison, and prison or jail.
Yeah, and most I've seen, when it is a vendor that provides the healthcare, yeah, they pay for it just like any other surgery. And there have been a bunch now, like the Idaho case, but there's been several in Massachusetts, a lot in California, and some aren't vendor. They're state and medicals through the state, and then the state pays. But
Yeah,
the
right. They might
State-
have to duke it out with their
Yeah.
vendor, the state, between the state and the vendor, about who
Yeah.
pays, but that's not your problem as a provider. I think
Right.
if the decision has been made and you've ordered the treatment, it better happen. That's fundamental to Estelle Gamble, right?
Yep, absolutely. And then the Medicaid question. So years ago, there was a Medicaid reviews issues like this, and they looked at surgery and said, yes, folks need surgery to treat dysphoria in some cases, but it's going to be case by case. So what they said about 10, 12 years ago is exactly what we should do in corrections. That it's not like any medical intervention, right? You don't just automatically get X for this disorder. You have an evaluation, there's a diagnosis, and then you determine what that specific intervention is, the dosage and all that. So, and that's what Medicare said with surgery.
Thank you.
Will the slides be available for review is a final question, and I'm going to leave. How do you want to handle that, Joel? I now have your PowerPoint. I can distribute it to people who have asked me for it. If you're
Yep.
okay with that, I don't
Absolutely.
think there's, from my end, there's nothing proprietary about this presentation for the ACCP.
Oh.
The videos are protected; they're our property, but but they're going to be in the public domain anyway. And I'll
Right.
just remind everybody that so they're our property, but they're in the public domain. And I'll just remind everybody that if they want to look at this going forward, that this and all of these 20, I don't know how many there are now, but 25 or so presentations should be in the public domain in the near are already or should be in the near term. And we've gone significantly over 10 minutes. This is probably one of our longest yet. And I think I think though that there's enough controversy in this area that I expected this one to go over and that it's appropriate. So I appreciate everybody's patience. Some people dropped out, but we got nearly 50 participants, and that isn't counting the people who will watch later. So I'm very pleased, and I hope that people will continue to participate in these sessions. We have an April session planned around program development in a prison setting, but it'll apply to jail settings. That's coming up in April. I believe it's April 15th, the earliest time that the third Wednesday can possibly happen. And I look forward to seeing many of you there. And we'll keep on publicizing these as widely as we can. And we depend on you, the participants, who have seen that this is a good program to spread the word to your colleagues and friends about this educational opportunity. And Joel, I'm just so grateful. Thank you so much. And please when you have an opportunity, thank our speakers. Every one of them is voluntary. Every one of them spends significant amount of time on preparing this. I try to encourage people to use a talk that they've already given, but there's always, it's got to be tweaked and made specific to our group, and we all understand that, and we're so grateful. Joel, thank you.
Thank you all. I appreciate you, Mike, and this whole group. So thank you anytime.